Very good morning to the audience and the chairpersons. It is my great pleasure to be in the present in the Asian Heart Society meeting for the consecutive last 4 or 5 years, and I'm very much grateful to Professor Kozi to remember me and to invite me every year. So, and he made a very good introduction on this topic about today's session, the heart failure with preserved ejection fraction. And in the next few minutes, I will be talking about the inflammation, how it drives the development of the heart failure with preserved ejection fraction. And over the last few years, there is a number of the trials which show that there is some relationship between the inflammation and the heart failure, the preservation failure, particularly obesity type of the HFpEF. And visceral adiposity is a source of inflammation in the HFpEF, and it is to be regarded as a pathophysiology for the development of the HFpEF as well as the propagation or the progression of the HFpEF. And the markers of the inflammation, such as the interleukin 6 and the CRP, are associated with the worse symptoms, worse quality of life, decreased exercise capacity, and poor prognosis of the HFpEF. And the pharmacologic inhibition of the inflammation has been shown to reduce the heart failure events in patients with the previous myocardial infarction and elevated CRP. It was documented in the different trials, and it is not a topic of today's. It has been discussed for the last many years. You see, there is a 2016. There is an article, "Inflammation of the Heart Failure with Preserved Ejection Fraction, Time to Put Out," and published in the JACC, Heart Failure. And they say the systemic inflammatory state is central to the common comorbidities associated with the HFpEF, and oxidative stress and endothelial dysfunction are prominent features. And they suggest that the anti-inflammatory therapeutic intervention to the inflamed HFpEF phenotype in large-scale clinical trials are needed. This is in 2016, about 9 years back. And in 2013, there is an article published in the as the obesity and diastolic heart failure is the inflammation a link. In 2014, there is another article in the Heart Failure Review, role of inflammation in the pathogenesis of the HFpEF and its potential as a therapeutic target. Again, in 2015, there is an article, Inflammation in HFpEF, key or circumstantial. And in 2021, chronic low-grade inflammation in HFpEF. So it has been discussing, the topic has been discussed for the last many years, and now it has taken some sort of a definite form. And it is a causal factor. Different trials show that it is a causal factor in both the pathogenesis and the propagation, as I have already told. Excess adipose tissues strongly promotes the inflammation and sustains the unabated immune pathway dysregulation. So the obesity is an important driver of the inflammation, and that drives to development of the HFpEF. The inflammatory environment in people with obesity is largely ascribed to the increased production of the adipose cytokines from the visceral adipose tissue deposits. It is the last year in the JACC. So this is a very common. So this is the common schematic diagram. It shows that the arterial hypertension, COPD, metabolic syndrome, obesity included, and diabetes mellitus, the renal failure, CKD, and even the decreased iron deficiency. All these factors lead to the inflammation, and that lead to the endothelial dysfunction, that lead to the diastolic dysfunction and HFpEF. And on the right hand side, there are the points of the different inflammatory pathways that lead to the myelofibrosis and the development of the diastolic dysfunction. And high sensitivity C-reactive protein in the heart failure with preserved ejection fraction. In the TOPCAT study, it has been found that the CRP is widely used as they assess the systemic inflammation, and identification of the chronic low-grade inflammation is made by measuring the high sensitivity C-reactive protein. It is 2 or more is the identified as the high risk of the heart failure events and the cardiovascular mortality. So, though there are many inflammatory markers, particularly in the clinical trials, the CRP and the interleukin 6 is taken as the marker of the inflammation. And in the STEP HPEP program, it is a semaglutide and the HPEP study, but the secondary analysis shows that the 71% of the 1,100 patients had evidence of the inflammation, that is the CRP2 or more. So there is a highly prevalent in the inflammation is highly prevalent, and larger semaglutide mediated reduction on the anti-proBNP reduction in inflammation plays a role in the decongestive effects of the semaglutide. In the semaglutide, those cases where there is a CRP level is reduced, they have got the better prognosis than the other cases. So the semaglutide lowered the CRP level, and efficacy of the CRP reduction is confirmed in both the very landmark trial of the STEP HPEF and the STEP HPEF DM in diabetic patients. So the same things, in 20% of the patients there is a high levels of the inflammation. CRP more than 10 potentially suggests a presence of ongoing inflammatory condition as well as the poor prognosis of the patients. Another agent is the GLP-1 receptor agonist as promising anti-inflammatory agents in the HPEF. It is also significant. HPEF is a significant challenge for the management because there is no definite drug as contradiction of the HPEF. So diabetes, visceral obesity, aging lead to systemic inflammation that plays a pivotal role in the pathogenesis, and the significant reduction on the CRP levels is associated with improvement, indicating the role of the anti-inflammatory effect of the GLP-1 receptor agonist. And this is the trial which has been published just last year, as some speaker was telling about the Hermes trial. That is the effects of the giltivekimab. This is the monoclonal antibody that reduces the CRP level, but in the normal weight patient, not the obese patient, not the overweight patient. That is, the previously in the semaglutide was thought to reduce the HPEF, improve the HPEF condition due to the reduction of the weight as well as the reduction of the CRP level. But these are the patients, more than 5,600 participants, they are the normal body weight. And this human monoclonal antibody directed against the interleukin 6, and they show that even in the normal patient, the semaglutide can or this monoclonal antibody which reduces the inflammation, not the weight, they also improves the prognosis. So there is a state of the art review in 2020, some years back. They also asserted that it is associated with the heart failure is associated with measures of systemic inflammation. Both the heart failure reduces infection as well as the HPEF, and mechanistic link there is a in between the inflammation and the heart failure, and the relationship between the inflammation of the heart failure is bidirectional, complex, and only partially understood. But it is in 2020. It is now better understood in 2025. And I don't like to go through the pictures again. Only the thing is the same thing. The cardiac injury, ischemic or non-ischemic, and systemic inflammation, either infectious or non-infectious, all lead to the enhanced interleukin activity that lead to the systolic dysfunction, diastolic dysfunction, and impaired contractile discharge and heart failure. These are how the interleukin takes place. And another is the humoral immunity. Here the skeletal muscles, the gastrointestinal tract, the spleen, and the adipose tissue. All these cause the inflammatory markers to affect the heart. So leading to the failure of the heart, particularly in the heart failure with preserved ejection fraction. And this is the same thing. The comorbidities lead to the systemic inflammation and the multi-organ involvement in the inflammatory process. There is article published last year in the JACC Heart Failure, the Inflammation and the Cardiorespiratory Fitness in HFpEF, a decade of progress, a systemic inflammation event in the presence of the controlled risk factor increases the risk of the cardiovascular disease. This is called the residual inflammatory risk. When the other factors are the control, even there is a risk of the increased risk of the HFpEF. CRP may be an adequate marker of the inflammation. In DRD study, there is a study treatment with the anakinra, the anti-inflammatory agent associated with the reduction of the CRP, and this is the published in the JACC Heart Failure. So there is the inflammation as a therapeutic target. This is the new horizon of the management of the heart failure, particularly HFpEF. The term meta-inflammation has been used to describe the association of the metabolic stress caused by the condition diabetes, obesity, insulin resistance, and non-alcoholic fatty liver disease, and that lead to the chronic inflammation. A number of the clinical trials are ongoing targeting the inflammation on the HFpEF. Inflammation remains a viable treatment target in the HFpEF because the only drug that has been approved by the FDA is the SGLT2 inhibitors, the class 1 indication in the HFpEF. Next is the ARNI, and next is the you may use the spironolactone also. Inflammation remains a viable treatment target in the future. And this is the same thing, the repetition only. So there is a different types of the inflammatory markers. I am not going to detail it, only the things that the number of the inflammatory markers. So it is easy to target the inflammation by looking at the particular inflammatory marker. So that there may be a lot of agents in the future that may be helpful in the reducing the inflammation and the improvement of the HFpEF patients. So the SGLT2 inhibitors are possibly related to both the direct and indirect mitigation of the inflammatory signaling pathway independent of the glycemic pathway. So these are the signaling pathways. The proposed mechanism is the GLP-1 receptor agonist. They reduces the obesity, thereby the inflammation is reduced. They also reduce the direct inflammation, thereby reducing the coronary artery disease, atrial fibrillation, hypertension, and particularly the GLP-1 again the inflammatory pathway interferes with the inflammatory pathway, leading to the improvement of the HFpEF patients. So, is targeting the inflammation is the key to unlocking the HFpEF. Focus on the anti-inflammatory. In essence, we stand at a juncture where our understanding of this complete relationship is not yet complete. Though we see that there is a very bright future of the anti-inflammatory agents in the management of the heart failure patients, particularly the HFpEF. So, ladies and gentlemen, having said so, the take-home message is inflammation can be both cause and consequence of the heart failure and plays a central role in the disease pathogenesis and prognosis. Obesity is the central point for chronic inflammation of the HFpEF with obesity. SGLT2 inhibitors, empagliflozin, and GLP-1 receptor agonist, semaglutide, advise different trials are found to improve the clinical status and reduce the inflammatory markers in patients with the heart failure. A number of the inflammatory markers are implicated in the process of the inflammation. In the study, CRP is taken as the inflammatory marker in most cases, and as well as the interleukin-6. Clinical trials are directed anti-cytokine and anti-inflammatory therapies will determine the role of inflammation in details in the pathogenesis of HFpEF and the role of the anti-inflammatory agents in its management. I think this is the end. Thank you very much for the patient hearing.